Hi, welcome you. I am Dr. Tin. I hope you would be interested to learn about congenital heart diseases in children. First of all, I am going to tell you a case scenario of a baby girl with congenital heart defect. An 8-week-old baby girl presented with lethargy, poor feeding, and respiratory distress. She was previously well until 1 week ago when she developed worsening rapid breathing. She also had sweating during feeding. On examination she was afebrile, her respiratory rate was 60 breaths per minute and heart rate was 160 beats per minute. Blood pressure was 80/50 mm mercury, oxygen saturation in room air was 99%. She had subcostal and intercostal recessions. Her first and second heart sounds were normal with a grade 3 pansystolic murmur best heard over lower left sternal edge. The liver edge was palpable 4 cm below the right costal margin. What is the most likely diagnosis? What are the investigations and management for this patient? At the end of this lecture, students should be able to understand pathophysiology, recognize the common presentations, know how to diagnose different types, formulate principles of management of congenital heart diseases in children. First of all, I would like to refresh your knowledge on the normal anatomy and blood flow of the heart. This is a diagram of a normal heart with 4 chambers, which demonstrates the blood flow inside the heart and its main vessels. Firstly, deoxygenated blood from all over the body, which is shown as blue color in the picture, reaches right atrium through the superior and inferior vena cava. It then passes through the tricuspid valve into the right ventricle and is subsequently pumped out to the lungs for oxygenation via pulmonary artery. Oxygenated blood, shown as red color in the picture, returns from the lungs via pulmonary veins into the left atrium. It then passes through the mitral valve into the left ventricle, and is subsequently pumped out to the whole body via the aorta to supply oxygenated blood for tissue metabolism. There is a septum between each atria and ventricles, so there is no mixing of deoxygenated and oxygenated blood. Now let's talk about congenital heart diseases. We can classify them as cyanotic, and obstructive types. The commonest cyanotic congenital heart disease is ventricular septal defect or VSD, which accounts for 30% of these problems. Other less common ones are patent ductus arteriosus or PDA, and atrial septal defect or ASD, which account for 12 and 7% of congenital heart diseases respectively. In these 3 conditions, there is shunting of blood from left to right side of heart. The patients are pink and generally asymptomatic at birth. In cyanotic congenital heart diseases, the patients have central cyanosis with bluish tongue due to lack of oxygen in the body. The commonest are TETRALOGY of FALLOT or TOF and TRANSPOSITION of great arteries or TGA. In the obstructive type, there is narrowing of heart valves or major blood vessel. The examples include coarctation of aorta, pulmonary stenosis and aortic stenosis. Let's start with cyanotic congenital heart diseases. I'll explain the 3 main conditions, which are ventricular septal defect, patent ductus arteriosus, and atrial septal defect. In general, patients with small VSD, PDA and ASD are asymptomatic and only have murmurs on examination. Investigations such as ECG and chest X-ray are normal and they are treated conservatively as most of them will close spontaneously. On the other hand, patients with larger lesions may have symptoms and signs of heart failure. They also may require surgical closure. First, I will discuss the ventricular septal defect or VSD in terms of its characteristic features, symptoms and signs, investigations, management, and complications. Ventricular septal defect is characterized by the presence of defect in the ventricular septum. There are two main types: perimembranous and muscular VSD. This picture illustrates the location and blood flow through the VSD. The right upper picture shows perimembranous ventricular septal defect, and the right lower one is the muscular type. As illustrated in the picture, there is shunting of blood from left to right side of the heart through the septal defect. The resultant increase in pulmonary blood flow is significant, especially in large ventricular septal defect, leading to pulmonary edema and heart failure. The symptoms and signs of ventricular septal defect depend on the size of the lesions. Most patients with small ventricular septal defect are asymptomatic and diagnosed incidentally during clinic visit for other reasons. On the other hand, patients with large ventricular septal defect usually presents in infancy with symptoms of heart failure, such as sweating and rapid breathing during feeding, as well as interrupted and prolonged feeding. On examination, the characteristic finding of a ventricular septal defect on auscultation is pansystolic murmur best heard over lower left sternal edge. Patients with large ventricular septal defect may have signs of heart failure, which are failure to thrive, tachypnea, tachycardia, displaced apex beat due to cardiomegaly, crepitations in the lung due to pulmonary edema, and hepatomegaly due to liver congestion. In small ventricular septal defect, the ECG and chest X-ray are normal. In large ventricular septal defect, the ECG may have evidence of biventricular hypertrophy. Chest X-ray may show cardiomegaly with increased pulmonary vascular markings. Echocardiogram is the diagnostic tool to demonstrate the presence of the ventricular septal defect and its size. Small ventricular septal defect is usually treated conservatively as it may close spontaneously. Large ventricular septal defect that presents with symptoms and signs of heart failure should be started on anti-E failure such as furosemide. Captopril can be added later. Fluid intake should be restricted in acute heart failure. Early surgical closure is indicated if the heart failure is not controlled despite optimized medical therapy. Prolonged left to right shunting produces pulmonary hypertension, causing increased pressure in right side more than left side, which subsequently leads to reversal of blood flow through the shunt. Ultimately, deoxygenated blood goes to systemic circulation and patient presents with cyanosis. This is called Eisenmenger syndrome. Another important complication is infective endocarditis. It is an infection of the endocardial surface of the heart, which may lead to intractable congestive heart failure and myocardial abscesses. If left untreated, it is generally fatal. Next I will discuss the patent ductus arteriosus or PDA in terms of its characteristic features, symptoms and signs, investigations, and management. Now let's talk about patent ductus arteriosus. Ductus arteriosus connects the pulmonary artery to descending aorta in fetus but normally closes shortly after birth. Failure to close after birth leads to patent ductus arteriosus. In this condition, the blood flows from aorta into pulmonary artery, so there is left to right shunt. The symptoms and signs of PDA depend on the size of the lesions. Most patients with small PDA are asymptomatic and diagnosed incidentally during clinic visit for other reasons. On the other hand, patients with large PDA usually present in infancy with symptoms of heart failure as explained earlier. On examination, the characteristic finding of a PDA on auscultation is continuous murmur best heard over upper left sternal edge. Patients with large PDA may have bounding pulses and signs of heart failure. In small PDA, the ECG and chest X-ray are normal. In large PDA, the ECG may have evidence of left ventricular hypertrophy. Chest X-ray may show cardiomegaly with increased pulmonary vascular markings. Echocardiogram is the diagnostic tool to demonstrate the presence of PDA and its size. Small PDA is usually treated conservatively as it may close spontaneously. Patients with large PDA that presents with symptoms and signs of heart failure should be started on anti-failures as explained earlier. Early PDA ligation is indicated if the heart failure is not controlled despite optimized medical therapy. Closure of PDA in older children be done using coil or occlusion device introduced via a cardiac catheter. Next I will discuss the atrial septal defect or ASD in terms of its types, symptoms and signs, investigations, and management. Now let's talk about atrial septal defect. There are mainly two types, which are secundum ASD, which accounts for 80% of all ASD, and primum ASD, which accounts for another 20%. The symptoms and signs of ASD depend on the size of the lesions. Patients with small ASD are asymptomatic and diagnosed incidentally during clinic visit for other reasons. Sometimes, patients with large ASD presents in infancy with symptoms of heart failure as explained earlier. However, this is much less common compared to those with ventricular septal defect and patent ductus arteriosus. On examination, the characteristic finding of an ASD on auscultation is wide fixed splitting of second heart sound and ejection systolic murmur over upper left sternal edge. Patients with large ASD may have signs of heart failure. However, this is an uncommon manifestation of patients with ASD. In small ASD, the ECG and chest X-ray are normal. In large ASD, the ECG may have evidence of right bundle branch block. Chest X-ray may have cardiomegaly with increased pulmonary vascular markings. Echocardiogram is the diagnostic tool to demonstrate the presence of the ASD and its size. Small ASD is usually treated conservatively as it may close spontaneously. Patients with large ASD that present with symptoms and signs of heart failure should be started on anti-failures as explained earlier. Closure of secundum ASD in older children can be done using occlusion device introduced via a cardiac catheter. Surgical closure is indicated for primum ASD. Now I would like to discuss cyanotic congenital heart diseases. The two main conditions under this category are tetralogy of FALLOT and transposition of great arteries. First I will discuss the tetralogy of FALLOT or TOF in terms of its characteristic features, symptoms and signs, investigations, management, and complications. Tetralogy of FALLOT is the most common cyanotic congenital heart disease. It consists of 4 structural defects: overriding of the aorta, ventricular septal defect, pulmonary stenosis, and right ventricular hypertrophy. Patients with TOF may present with feeding difficulties and failure to thrive. On examination, the child has central cyanosis. On auscultation, there is an ejection systolic murmur at upper left sternal edge. The murmur is due to pulmonary stenosis. Clubbing of fingers and toes is noted in older children. In TOF, the ECG typically shows right ventricular hypertrophy. Chest X-ray shows boot-shaped heart with reduced pulmonary vascular markings or polygenic lung fields. Echocardiogram is the diagnostic investigation for TOF. Infants who have severe cyanosis need intervention to increase the pulmonary blood flow. Firstly, prostaglandin is given to maintain the patency of ductus arteriosus. This is a temporary measure during neonatal period. The Black-Lactalsig shunt is done later. This is the placement of an artificial tube between the subclavian artery and one of main branches of pulmonary artery. which serves to increase the pulmonary blood flow. Definitive surgery is generally done when the patients are older. Hypercyanotic spell typically occurs when the child cries. This causes infundibular spasm, leading to increase in right ventricular outflow tract obstruction, which in turn leads to increase in right to left shunt. Therefore, the patient presents with worsening cyanosis, irritability and breathlessness. It may lead to myocardial infarct, cerebrovascular accident or even death. When this happens, we need to keep patient in the chest position. Squatting may relieve the cyanosis in bigger child. If these simple measures are not effective, administration of intravenous morphine and propranolol is beneficial. Polycythemia is also common in TOF patients. This is because the hypoxia stimulates increase in erythropoiesis. Another important complication in TOF patients is brain abscess. The right to left shunt of venous blood in the heart bypasses the pulmonary circulation, which is a site of immune system. Thus, bacteria in the bloodstream are not filtered through the pulmonary circulation, where they would normally be removed by phagocytosis. These patients also have areas with low perfusion in the brain due to chronic severe hypoxemia. These areas are prone to seeding by microorganisms that may be present in the bloodstream. Next I will discuss the transposition of great arteries or TGA in terms of its characteristic features, symptoms and signs, investigations, and management. In TGA, the aorta arises from the right ventricle and the pulmonary artery arises from the left ventricle. Hence, the oxygenated blood returning to the right side of the heart is pumped out to the body, while oxygenated blood returning from the lungs enters the left side of the heart and is pumped back to the lungs. Classically, the baby with TGA presents with severe cyanosis after few hours of life. This occurs after the closure of ductus arteriosus. The baby usually has no heart murmur unless there is other associated defect. In TGA, the ECG is usually normal. Chest X-ray classically shows narrow upper mediastinum with an egg-on-side appearance of the cardiac shadow. Echocardiogram is the diagnostic investigation for TGA. The key management in TGA is to improve mixing of blood between the right and the left side of heart. This is achieved by commencing the baby on intravenous prostaglandin infusion, which will maintain the patency of ductus arteriosus. Subsequently, balloon atrial septostomy can be done to improve mixing of the blood. Arterial switch operation is the definitive surgery. This is usually performed at 2 to 4 weeks of life. Finally, let's move on to the congenital obstructive heart diseases. The common ones are coarctation of aorta, aortic stenosis, and pulmonary stenosis. I will only discuss each topic briefly. In coarctation of aorta, there is narrowing of the aorta. It occurs most commonly in the segment just after the aortic arch. On examination, the patient may have upper limb hypertension where blood pressure is higher in the upper limb compared to the lower limb, and diminished femoral pulses or radiofemoral delay. In aortic stenosis, there is narrowing of the aortic valve, causing a decrease in blood flow to the whole body. On auscultation, there is an ejection systolic murmur in the upper right sternal edge, radiating to the neck, which increases on expiration. In pulmonary stenosis, there is narrowing of pulmonary valve, causing a decrease in blood flow to the lungs. On auscultation, there is an ejection systolic murmur over upper left sternal edge, which increases with inspiration. In summary, congenital heart diseases can be divided into acyanotic, cyanotic and obstructive problems. The main causes of acyanotic congenital heart diseases are ventricular septal defect, patent ductus arteriosus and atrial septal defect. The main causes of cyanotic congenital heart diseases are tetralogy of FALLOT and transposition of great arteries. The main causes of obstructive congenital heart diseases are aortic stenosis, pulmonary stenosis and coarctation of aorta. These are the references for this topic. I would like to thank you for giving attention till the end of the presentation. I hope you would understand the topic of congenital heart diseases in children.